Hi and welcome back to another video of Medic Notes. This video is on posterior cerebral artery stroke. For introduction of the blood supply in brain. Anterior and posterior circulations provide the primary blood circulation of the brain. Both circulations are connected by the posterior communicating arteries, which make up the circle of Willis. Posterior circulation is supplied by vertebral arteries, posterior inferior cerebellar arteries, basilar artery, anterior inferior cerebellar arteries, pontine branches of the basilar artery, superior cerebellar arteries, posterior cerebral artery, and posterior communicating artery. The anterior, middle and posterior cerebral arteries each supply a specific territory of the brain. The anterior cerebral arteries supply the anteromedial area of the cerebrum. The middle cerebral arteries supply the majority of the lateral cerebrum. The posterior cerebral arteries supply a mixture of the medial and lateral areas of the posterior cerebrum. A posterior circulation syndrome involves damage to the area of the brain supplied by the posterior circulation. One of the following need to be present for a diagnosis of a POCI: cranial nerve palsy and a contralateral motor or sensory deficit, bilateral motor or sensory deficit, conjugate eye movement disorder like horizontal gaze palsy, cerebellar dysfunction like vertigo, nystagmus, and ataxia, or isolated homonymous hemianopia. There are many possible causes of POCI, where the most common causes are still atherosclerosis, embolism, and small artery disease. Stroke, a leading cause of adult disability, is the fifth leading cause of death in the United States. A stroke is reported every 40 seconds, and every 4 minutes someone dies from a stroke. Patients may present with different signs or symptoms when PCA restricts the blood supply of multiple brain regions. Atherothrombosis can cause an artery-artery embolism, complete branch, or in situ occlusion, and hemodynamic instability. Small artery disease includes lipoalanosis and hyaline arteriolosclerosis of small arteries. It is likely due to hypertension, diabetes, and aging. For visual field defects, PCA and deep branches of MCA supply the optic radiations. The lower part of the optic radiations receives blood supply from the PCA. The upper part gets blood supply from the MCA. Unilateral infarctions of the occipital lobe may cause contralateral homonymous hemianopia with macular sparing. Visual field defects, hemisensory deficit, and neuropsychological dysfunction may be seen after occlusion of the posterior choroidal artery. Bilateral infarction of the occipital lobes may cause cortical blindness. Other visual dysfunction include visual agnosia, prosopagnosia, alexia, and achromatopsia. Cognitive and behavioral dysfunction, such as aphasia, memory impairment, aggressive behavior, hallucinations, and palinopsia. Stroke is an emergency, and the timing of the onset of symptoms is the most important information in acute settings. Time of onset can be challenging in posterior circulation strokes because patients may be unaware of their symptoms. Patients may present in a comatose state via ambulance or may walk to an emergency department without assistance. Patients with a PCA stroke may present with only a headache and mild visual changes such as vision loss, diplopia, inability to see half of the view, or difficulty reading perceiving colors, or recognizing familiar faces. Patients may report visual problems such as grayness, spots, voids, and difficulties focusing. Patient history may include unilateral weakness, sensory deficits, language dysfunction, dizziness, nausea, vomiting, cognitive and behavioral disturbances. For physical exam, National Institutes of Health Stroke Scale, NIHSS, is a systematic assessment tool that provides a quantitative measure of stroke-related neurologic deficits. The score ranges from 0, no deficit, to 42, which is the maximum score. A cardiovascular exam also should be performed to check for carotid bruits and abnormal rhythm or heart sounds as well as signs of a DVT. For blood investigations, full blood count, COG profile, electrolytes, lipid profile and HbA1c, and other extra autoimmune tests. Imaging such as CT brain, MRI, or CTA can be done. And cardiology tests like ECG, chest X-ray, echo, and Holter test. For treatment, patients with EHIS should be checked for airway, breathing, and adequate oxygenation. Intravenous tissue plasminogen activator can be administered up to 4.5 hours after acute ischemic stroke. A patient with acute ischemic stroke may present after a 4.5-hour window and might still be a candidate for endovascular treatment, which may include angioplasty, stenting, mechanical embolectomy, or intraarterial thrombolysis. The rest of the treatment should be focused on preventing further cerebrovascular accidents. Antiplatelet or anticoagulation should be started based on the etiology of the stroke. Other secondary risk factors should be addressed with better controlled hypertension, cholesterol, and diabetes. For its prognosis, stroke is a leading cause of disability and the fifth leading cause of death in the United States. The disability and mortality are less likely from pure PCA stroke compared to other strokes. That's all for this video. Thank you.